Valvular cardiac surgery. Outline heart and heart valve A&P valvular pathology. Valvular diagnostics. Open heart patient preparation. Supplies, instrumentation, and equipment. Valve surgery, aortic, mitral, tricuspid. Ventricular aneurysmectomy. A&P. Your heart's valves. Normal circulation. Blood comes back to heart for reoxygenation via the superior and inferior vena cava entering into the right atrium. Passes through the tricuspid valve into the right ventricle, then through the pulmonic valve into the pulmonary artery. Blood is reoxygenated in the lungs, and returns via the pulmonic veins into the left atrium. There it goes through the mitral valve into the left ventricle through the aortic valve, pushing oxygenated blood into the coronary ostia as it passes them and throughout the rest of the body where oxygen is needed by all the organs and tissues. Cardiac valves. Tricuspid valve lies between the right atrium and right ventricle. Blood returns to the heart through the superior and inferior vena cava into the right atrium where it passes through the tricuspid valve into the right ventricle where it is pumped through the pulmonic valve into the pulmonary artery to be taken to the lungs for reoxygenation. Cardiac valves. Mitral valve lies between the left atrium and the left ventricle. Blood returns via the pulmonary veins, after reoxygenation, into the left atrium, passes through the mitral valve and into the left ventricle, where it is pumped through the aortic valve. Cardiac valves. Aortic valve lies between the aorta and the left ventricle. Blood is pumped from the left ventricle through the aorta to the coronary ostia, head vessels, upper and lower extremities, and the abdominal organs, via the aorta. Clarification. The aortic and pulmonic are often referred to as semilunar, meaning they have three half-moon-shaped cusps. The mitral and tricuspid are often referred to as atrioventricular valves, as they separate the atria and ventricles. The tricuspid valve is three-cusped. The mitral valve is two-cusped or bicuspid. Mitral valve has two cusps, a posterior and anterior leaflet, often referred to as the bicuspid valve. Leaflets are attached and anchored to the endocardial papillary muscles by cords called chordae tendineae. Chordae tendineae keep the valve from prolapsing. Cardiac conduction coordinates. Cardiac conduction. SAR node, sinoatrial, the pacemaker. Avenue node, atrioventricular. Bundle of his or avenue bundle. Down RL insulated branched bundles in ventricular septum. Perking fibers non-insulated and feed into RL ventricles. Cardiac conduction. SHA node initiates impulse greater than atria contract, blood forced into ventricles greater than stimulus picked up by avenue node greater than avenue bundle, signal slightly delayed, greater than Burnached bundles greater than perking fibers greater than ventricles stimulated and contract, blood forces atrioventricular valves to close and semilunar valves to open. These valves should go one way. Pathology of valves. Obstruction of the valves is usually caused by stenosis or fusion of the leaflets causing diminished blood flow resulting in poor oxygenation or backup of blood into the respective ventricles. Backup of blood damages the ventricular endocardium and myocardium over time, which can cause ventricular aneurysm, thinning and enlargement of the ventricle. Can be regurgitant or insufficient due to leaflet damage, may not necessarily be stenosed. In the case of the mitral valve, damage can be to the chordae tendineae, causing elongation, rupture, or shortening. Aortic stenosis, calcification of the aortic valve cusps. LV hypertrophy develops as a result of restricted blood flow into the aorta. SX, fatigue, DO, palpitations, dizziness, fainting, angina, chest pain. Pulmonic stenosis, calcification of pulmonic valve cusps. Restricts flow into PA. RV hypertrophy. Mitral regurgitation. Blood flows back, regurgitates, into the LA through the incompetent mitral valve. LV hypertrophy. SX, fatigue, palpitations, orthopnea, need to sit up to breath, PND, paroxysmal nocturnal dyspnea, after sleeping wakes up needing air. Mitral stenosis, calcified mitral valve impedes flow of blood into LV. LA hypertrophy or enlargement. SX, fatigue, palpitations, DO, orthopnea, PND, pulmonary edema. Tricuspid regurgitation. Blood flows back, regurgitates, into RA due to incompetent tricuspid valve. SX, engorged pulsating neck veins, liver enlargement, RV hypertrophy, thrill at left sternum. Tricuspid stenosis, calcification of tricuspid valve. Impedes blood flow into RV. SX, diminished arterial pulse, jugular venous prominence. Valvular disease causes, CAD and ME degenerative disease due to age. Rheumatic heart disease, a complication of bacterial strep. Congenital disease. Obstruction results in left ventricular myocardial overload due to backflow of blood, which stresses the myocardium over time. 4. Drug abuse. Dental infections. Lupus. Marfan's syndrome. Scleroderma. Symptoms of valvular disease. Fatigue. Weakness. Dyspnea with or without exertion, stress, or pregnancy. Pulmonary edema. 1 degree cause rheumatic fever. May go from mild to total disability in 5–10 years. May be asymptomatic 10 to 20 years after initial damage to valve. Diagnosis: non-invasive H&P ECG/EKG, exercise EKG, stress test. Echocardiogram. Echocardiography is the gold standard for diagnosing valvular disease. Chest X-ray, diagnosis. Invasive. Cardiac catheterization, may be in conjunction with echocardiogram. Transesophageal echocardiogram, usually done preoperatively in the OR suite in conjunction with valve surgery. Anesthesia. General. Medications: warm saline with antibiotic solution. Topical hemostatic agents of choice: Surgical, gel foam and thrombin. Gel foam/thrombin/antibiotic rolled into balls for sternal bone application. Bone wax for sternum with latex underneath to prevent surgeon from ripping gloves on rough edges. Extra NS for valve rinsing if is a xenograft. Will rinse X3 in 250 cc NS each, rinse for 2 minutes each or per manufacturer's recommendations. Some surgeons may want antibiotic added to second or third rinse. Patient positioning: supine position, arms padded and tucked. May want a shoulder roll to elevate the sternum, optional. Headrest. Pillow under knees, preferable. Heel pads, preferable. Prep. Begin at anterior thorax, prepping outward in a circular motion to the bedline, prep to top of thighs/bilateral groins, then pubis. With a separate sponge, prep both legs to knees to the bedline. Use betadine soap, then paint. May use gel or spray. Should do minimum of 2 coats of paint. Prep. For a CABG and valve replacement, will prep sternum to neck, bedline to bedline, groins, pubis, then each leg circumferentially to ankles or feet. Institutional policy. Equipment: 2 large tables, back table and Mayfield. Mayo stand, for saw. Double ring. Prep tables X2. Slush machine/warmer. ECU X2. Cell saver, CPB machine. Off-table suction. External pacing box. Instrumentation open heart trays valve tray suture guide holder. Sternal retractor, Ankeny for aortic valve, and Cosgrove Orca-S for mitral or tricuspid. Finochetti. Sternal saw. Internal defibrillator paddles. Doctor's specials. Micro instruments needed if CABG done with valve surgery. Supplies valve custom pack, coronary pack for CABG/valve. CV drape pack. Gloves. Chest tubes. Suture guide inserts. Valve sizes for appropriate valve. Appropriate valves of surgeon request in the room. Miscellaneous suture, pericardial suture, cannulation suture, aortic retraction suture, for aortic valve only, valve repair or replacement suture, suture to close aorta or atrium, pacing wires, suture to sew in pacing wires, cutting needles to sew in chest tubes and pacing wires, sternal wires, fascia suture, subcutaneous, subcuticular. Coronary osteoperfusion catheters, auto-inflating, gummy tip, or Spencers, for aortic only. Supplies continued aortic cannula. Venous cannula, need to for bicaval cannulation, need for mitral valve surgery. Antegrade cannula, may just use retrograde and place this after aorta closed for aortic valve surgery / is placed for mitral valve surgery. Retrograde cannula. Medusa. Cardiac insulation pad. Myocardial temperature probe. Extra saline. 3 cycles for washing valve if using a xenograft, porcine or bovine. Valve replacement options. Mechanical. Biological. Diseased valve excised and replaced. Valve replacement options, aortic and mitral. 1. Mechanical. St. Jude or Star Edwards. Valve only. Conduit/valve available for aortic. Durable. Used primarily in young patients. Patient requires long-term anticoagulant therapy, not for elderly. Complications, emboli bleeding from other injury due to anticoagulant therapy. Valve replacement options, aortic or mitral. 2. Heterograft/xenograft. Biologic. May be bovine or porcine. Bovine pericardium is the new rage. Old porcine has a duration of 15 years. Bovine pericardial are thought to last longer / research inconclusive due to recent development. No anticoagulant therapy needed. Valve replacement option, aortic. 3. Aortic stentless. Biologic. Porcine. Durability good over age of 60. No anticoagulant therapy needed. Valve replacement options, aortic, mitral, pulmonic. 4. Allograft/homograft. Biologic. Cadaver from organ donor. Will measure annulus size with T. Will choose graft before incision made or as opening chest. Time will be required for proper thawing procedure to be implemented to prevent damage to the graft. Long-term. Limited availability. Valve replacement option, aortic. 5. Autograft, Ross procedure. Requires expert valve surgeon. Excision of patient's pulmonic valve to be used as the patient's new aortic valve. A pulmonic allograft will be used to replace excised pulmonic valve. Long-term. Limited availability of pulmonic allograft. Valve repair options: annuloplasty rings, mitral annuloplasty rings, tricuspid annuloplasty rings. Replacement versus repair. Aortic and mitral are replaced. Tricuspid in extreme situations can be replaced with a mitral valve. Mitral and tricuspid usually repaired with annuloplasty rings. Mitral may have to be replaced if attempted repair is unsuccessful. Annuloplasty rings. Used for repairing of the mitral or tricuspid valves. Mitral rings are a near to complete circle. Tricuspid rings are an incomplete circle or half circle. Sizes are half moon shaped and have T or M on them, will come with a malleable handle, bend it slightly for ease of sizing. Are differentiated between by T or M on the tag. Remove the mini pearl tag before passing it to the surgeon. Provide reduction of the dilated annulus. Often the tricuspid function will return to normal with the repair of the mitral. Valve repair/replacement procedure. Incision with number 10 blade. Cautery. May use curved Mayo scissors to ream under the xiphoid to loosen the fascia from the sternum. Sternal saw. Bone wax or gel foam powder mixed with saline or thrombin to make soft balls to spread on sternum. Wet laps folded in half, should have been soaked in antibiotic NS and wrung out. Sternal retractor. Cautery and debakis to open/dissect the pericardium. Pericardial sutures, may use pop of silk or Neurolon. Valve repair/replacement procedure. Dissect aorta from pulmonary artery to provide room to place aortic cross-clamp. Burst string cannulation stitches for aortic cannula, X2, venous cannula, and retrograde cannula, each is Rommelled. Heparin is administered by anesthesia at surgeon prompt. Cannulas are placed, aortic first, stab blade, number 11, aortic cannula, heavy tie or umbilical tape, tube clamp, bowl and scissors to cut aortic pump line, hook to CPB tubing. Make so cannula to patient/drape or clamp with non-penetrating towel clip. Venous cannula placed, Metz cannula. Some surgeons may use a Satinsky to clamp the atrial appendage before incising it. Heavy tie or umbilical tape, tube clamp or knot and hook to venous line from CPB machine. Surgeon will say to perfusion, go on bypass. Valve repair/replacement procedure. Hypothermia will begin by perfusion who can cool the blood he is circulating. Cross clamp will be placed across the aorta. Cardiac insulation pad may be placed. Myocardial temp probe may be placed near the apex of the left ventricle. Ice may be applied to the heart as well. Aortic valve replacement. Once temperature is where surgeon wants it, he will take a Metz and cut the aorta open above the aortic valve and below the aortic cross clamp. He may want stay sutures or attraction sutures. He may continue to perfuse the heart with cardioplegia fluid directly into the coronary ostia via the medusa and coronary perfusion cannula that is attached, his/her preference. Aortic valve replacement. He or she will begin to excise the valve using Metz, a pituitary wronger, knife, #15C or number 11. Be prepared to wipe wronger, Metz, and forceps frequently with a moist lap. Retraction may be provided by the assistant with a handheld aortic retractor. Off-table suction will be used to vacuum, tonsil suction without tip, as plaque is removed. Care is taken not to get debris into the ventricle as it could cause stroke later. Cold NS irrigation provides thorough cleaning using an asepto. Mitral valve repair/replacement. Caval tapes will be used with a ligature passer or right angle and long Dacron or polyester tapes and Rommel to provide a tight seal around the cavity and their cannulae to prevent blood from coming into the field around the cannulae. Heart is turned over and left atrium is exposed. Surgeon will take a number 11 or number 15 blade to open the atrium, long meds to widen the incision. Mitral retraction will be achieved with a handheld mitral/atrial retractor or placement of the arm attachments for the Cosgrove or Caress retractor. 2 long, blunt nerve hooks will be passed to the surgeon for him to manipulate the valve leaflets and determine location/extent of damage. Will repair by removing a leaflet, repairing the chordae tendinei with Gore-Tex, PTFE, or Prolene suture, have knife, mets, and nerve hooks available. One of the leaflets may be left to maintain ventricular configuration. If one passed to you, ask if it is the anterior or posterior for proper specimen labeling. Mitral valve repair/replacement. Once the annulus is cleaned or the chordae are repaired, the annulus will be sized using mitral sizers for the appropriate valve being used. Clarify the valve before obtaining it from the circulator. Valve sutures will be placed, double-load pledgeted valve sutures. Once valve sutures are in hand, up 3 NHs you will assist with loading the valve sutures in order to place through the annuloplasty ring or valve. Be sure you keep up with how many sutures are used. Valve repair/replacement procedure. Once valve annulus is clean, annulus is sized with appropriate sizer. Valve is passed to field after being verified by the circulator, scrub, and surgeon. Bovine and porcine valves require a rinsing process, 2 minutes in a minimum of 250 ml NS times 3. Baxter Edwards only require 1 minute x3. Sutures for valve are placed, pledgeted 2-0 RB1 Ethibond or CV316 Ticron. Pledgeted sutures are used for valve replacement/non-pledgeted for repair. Sutures will be passed double-loaded as all pledgeted sutures should. Once sutures are in, if valve is ready, 3 short NH will be passed up and the assistant, scrub, PA, and surgeon will work their way around the suture guide, loading each needle in sequence for the surgeon to pass through the valve. The sutures should have been counted before valve is up so the surgeon knows how far apart to place the sutures in the cuff of the valve. Valve repair/replacement procedure. After sutures are in, surgeon will ask for 2 Kellys and you, or he will cut the needles. He will pass them to you attached to the other Kelly. He will work the valve into the annulus of the excised valve. You should moisten the strings with NS as he seats the valve. He may take a knife at that point to release the insert holding the valve to the handle. He will work his way around, tying in the interrupted sutures. When done, he will take long tenotomy scissors and cut the strands just above the knots. He will test the valve leaflets with NS on an asepto, may use several. May want a short piece of a red rubber catheter attached to asepto for visibility as he is squirting the NS to test the leaflets. If mechanical, may use rubber-shodded DeBakey forceps or long cotton tip applicator to test leaflets. Valve repair/replacement procedure. Will close aorta with 2 Prolene sutures usually pledgeted with a corresponding on a 3-0 or 4-0 tapered RB1 or SH needle. Will close atrium with a 4-0 or 3-0 Prolene on a tapered SH or MH needle, usually non-pledgeted. Air is vented via antegrade placement, if was not in aortic. May need a 14 Gelco on a 60 cc syringe to stab the apex/ventricle of the heart to remove air within before discontinuing bypass. Valve repair/replacement procedure. Topical hemostatic may be used, gel foam pad strips with NS or thrombin. Patient may need to be defibrillated, have ready when closing aorta or atrium. CPD will be discontinued when patient is rewarmed. Mets, tube clamps, METs. Pacing wires will be placed, atrial and ventricular. Chest tubes will be placed, one mediastinal and one substernal. Sternal wires placed twisted and cut with wire cutter, irrigation of NS with antib, fascial layer, subcutaneous, hookup, plurivac after suctioning out the chest tubes, subcuticular. Dressing, steri-strips, telfer, 4x4s, primapore. Fluffs or 4x4s to chest tubes and tape. Ventricular aneurysm repair or ventricular aneurysmectomy. Result of myocardial damage after ANMI causing myocardial replacement with scar tissue. Scar stretches with pressure resulting in aneurysm formation. Is the excision of the portion of the ventricle that has become aneurysmic and reinforcing it with a patch of synthetic graft material, maybe PTFE or HemoShield. Often a tube graft is used and a circular patch is cut with it. Ventricular aneurysm repair or ventricular aneurysmectomy may require CPB. Prep/setup is as described for any open heart surgery with exception of if being done alone, you would not need a lot of the previously described items. Most frequently done in conjunction with CABG or valve surgery. May here referred to as the door procedure. Ventricular aneurysm repair or ventricular aneurysmectomy procedure. Incision made into the ventricle with a number 15 or number 11 blade extended with a MET. Will require retraction by the assistant with two Alices or Babcocks, are usually part of a valve tray of instruments. Surgeon may remove or excise a part of the scar tissue. A neck will be created in the rim of the scarring with a Prolene suture, 2-0 or 3-0 on an SH, to pull the tissue back together. Ventricular aneurysm repair or ventricular aneurysmectomy. Interrupted plegited Ticron or Ethibond sutures will be placed, 2-0 RB1 or CV316, SH or CV305. Patch will be passed up with 2 NH to place sutures through the patch. Patch will be eased down to cover the created neck. Myocardium will be closed with another 3-0 Prolene SH. Epicardium will be closed with 2 thinly cut strips of Teflon felt and 2 running 3-0 or 2-0 Prolene sutures on an SH or MH tapered needle. Ventricular aneurysm repair or ventricular aneurysmectomy. Surgery proceeds with patient rewarming if was cooled and discontinuation of CPB. Routine open heart surgery closure. Complications: hypothermia, infection, myocardial contusion, bleeding. Cardiac tamponade. Embolus. Valve malfunction.